All right, everyone. Today we're going to be looking at restrictive lung disease. We just did a lecture on obstructive lung disease, so this is kind of its counterpart, restrictive lung disease. We will go over the different causes of restrictive lung disease. And the good thing about restrictive lung disease is, although there are a lot of different causes of restrictive lung disease, we really just have to skim the surface on what we have to know about it, because most of these things are pretty rare, and many of them we will never see in our careers. But we will see them on exams, so I will try to teach you the best I can to be able to identify buzzwords, key features in vignettes, and things to look for in your patients moving forward. There are quite a few course objectives, mainly because of the spectrum that we're covering, and we're also talking about PFTs in this group of lectures, although we won't really talk about it in this lecture. There's a separate lecture for PFTs and acid bases, but these course objectives, because the lecture is given on the same day, cover both. Alright, so what are we covering in this lecture? So we're covering the general restrictive lung disease category. We'll briefly mention PFTs, kind of the signs and symptoms and diagnosis of restrictive lung disease. Then we'll start getting into the different specific causes for interstitial lung disease. Interstitial lung disease, idiopathic pulmonary fibrosis, sarcoidosis, and some of the occupational pulmonary diseases. So let's start with restrictive lung disease. What is restrictive lung disease? It's a big umbrella category for diseases or disorders that cause problems with the lungs and do not allow it to fill. It becomes restricted. And there's a large number of diseases that fall under the umbrella of restrictive lung disease. They are characterized by reduced distensibility of the lungs. They cannot fill with air. And so they can't expand, and the lung volumes are down because of it, and mainly the total lung capacity. So if you just watch the PFT lecture, or maybe you're going to watch it next, total lung capacity, reduced total lung capacity, is essentially the definition of restrictive lung disease. And it appears by both an intrinsic and extrinsic causes. So what do I mean by that? So total lung capacity is how much air you can fit in your lungs at the maximum inspiration. And anything that inhibits you from filling the lungs as full as you can is causing a restrictive process. Now, there are causes of restrictive lung disease that are innate, that are from the lung itself, and that's considered intrinsic restrictive pattern. And there are causes of restriction that are outside of the lungs, or extrapulmonary, and those are extrinsic causes. So some examples of intrinsic will be the things we're going to be covering today: interstitial lung disease, sarcoidosis, the pneumoconiasis. Extrinsic are going to be things outside of the lungs, like maybe kyphoscoliosis, Guillain-Barré, problems with paralysis of the diaphragm, and other things. So that's outside of the lungs. There's, like I mentioned already, the differential of pulmonary restriction is broad. It's very long. And by no means are we going to be able to touch on every single restrictive lung disease category like we could for obstructive. Obstructive is a much tighter box that we can fit things in. It can be caused by any of the interstitial lung diseases. And so some of the causes, like we mentioned, of extrinsic pulmonary restriction are going to be things that we talked about: kyphoscoliosis, neuromuscular disorders, spinal deviation. Obesity is a big one as well. Obesity, the extra fat and pressure putting on the lungs, makes it hard for the lungs to expand to their full capacity. And also ascites. Ascites is fluid in the abdomen, usually from cirrhosis of the liver, and that kind of pregnant looking belly full of fluid pushes up on the diaphragm and makes it hard to take a deep breath. I guess if you had to consider that, pregnancy could be a restrictive lung disease, and it's of course transitionary. It's not permanent, but that could also be considered kind of a restrictive lung disease. For this lecture, we are not going to focus on the extrinsic causes of restrictive lung disease, because we're in the PUL module. We're going to cover the intrinsic causes, the things that happen within the lungs that cause restrictive lung disease. So, kind of at a bird's eye view, like we mentioned, it's a heterogeneous group of diseases. Okay, chronic involvement of the interstitium and pulmonary connective tissue, decreased compliance, and increased elasticity. So it stretches out, and but it doesn't completely stretch. It has increased elasticity, but it has decreased compliance. So it just cannot go inflate and deflate like it should. Okay. I'm not going to go into the pulmonary function testing because we cover that in a separate lecture, but essentially the main thing we see with restrictive lung disease is a decreased total lung capacity. Okay. We also see a lot of fibrosis of the lungs. And I believe in your textbook, I read that there's about 180 or more different kinds of restrictive lung disease / interstitial lung diseases. So, like I said, we're really not going to touch on every single one. Kind of globally, what we see from a symptoms signs point of view is dyspnea. So it's usually at the beginning kind of exertional, like when I walk to the mailbox, I have a little bit of dyspnea, and then as the disease progresses, it's at rest, they have dyspnea. And they also tend to have kind of a non-productive cough, some fatigue, and then depending on which underlying disease is causing the restrictive lung disease, you have other symptoms, especially like those that are related to like connective tissue disease. So you'll have those kind of symptoms. So the rest of the symptoms are kind of related to the specific causes of restrictive lung disease. Signs tend to have these bibasilar crackles, digital clubbing from the chronic hypoxemia. They also have a lot of pulmonary hypertension, sometimes even cyanosis in advanced disease. We have P2, cor pulmonale, and pulmonary hypertension. And then in general, interstitial lung diseases classically produce the three C's: cough, clubbing, and coarse crackles on auscultation. In general, this is a very overview-y type slide. We'll get a little more specific when we go into the different causes of restrictive lung disease. But overall, chest x-ray, we use it, but it's not always specific. Can't really distinguish all the time between the different ones. It'll show interstitial patterns, nodular, honeycombing. High-resolution CT is much better at characterizing and quantifying the extent of the disease, and it helps. There are characteristic findings on high-resolution CT that can be helpful in diagnosing the specific cause of the lung disease. And they also helps pinpoint where to biopsy. PFT, as we already mentioned. UA you can get for glomerular injury that relates to like good pastures and granulomatosis, but we're not going to cover those in this lecture. A bronchoalveolar lavage is good. We can get the fluid. We can send for culture and cytology. And then last but not least, lung biopsy is the most accurate test, and it's used to confirm diagnosis. We don't always have to get a lung biopsy, but if we are unsure and we've kind of exhausted all the other means and we still can't figure out what it is, lung biopsy is going to be the most accurate test to do. Some of the characteristic findings we see, especially on CT, are honeycombing of the lung. And that is the way that honeycomb look, kind of like this. You can see kind of the extra space within the lung and the fibrotic changes around that space. So if you see honeycombing, if they say that in a vignette, you should be thinking of restrictive lung disease. All right? So now let's get a little more specific. We're going to talk about interstitial lung disease, which is abbreviated as ILD, and diffuse parenchymal lung diseases. So let's get going. Here's a list from your textbook, alphabetical list. It's pretty long, and this is by no means all of them. The textbook mentions there are over 180 different causes of interstitial lung disease. We are going to discuss some of the more common ones that are tested, and so I just want to make it perfectly clear that we will not cover all of these different disorders. Okay? Let's look at it from another perspective, kind of a bird's eye view again. So interstitial lung disease is also called diffuse parenchymal lung diseases. There's two names for it. And it's referred to disorders that have kind of similar clinical, radiographic, physiologic pathophysiologic manifestations, and it's within the lung itself, so in the interstitium, okay? Basically, when we try to decide what is causing the interstitial lung disease, either we figure out what it is or we don't. And in most cases, no matter what workup we do, we end up without a real cause. And that is what's termed idiopathic interstitial pneumonia or idiopathic pulmonary fibrosis. There are other types of idiopathic interstitial pneumonias, these others here, which I am not going to go into depth. We're going to focus on the idiopathic pulmonary fibrosis. It's the one that we see most often. And of all the interstitial lung diseases, this is the most common. And it's a diagnosis of exclusion. So you have to rule everything else out to be able to diagnose IPF. So what other things cause interstitial lung disease? Well, some of the things we're going to be talking about in our lecture are, one, inorganic exposures. These are usually work-related or occupational type exposures. We have already kind of mentioned briefly asbestos when we talked about mesothelioma. There's also silica, hard metals, coal dust, and other things that we'll talk about later on in the lecture. These are usually termed pneumoconiosis, okay? Then we have organic exposures, things like birds, hay, mold, bacteria. The one that I always think about when I think of organic exposures is like a farmer's lung, which comes from moldy hay. There's other things that can cause it. There's smoking can cause certain changes. There's some rare forms like vasculitis in lamb. There's also sarcoidosis, which is a granulomatous interstitial lung disease. We don't really know what causes sarcoidosis, hence it's under the unknown etiology, although we can make that diagnosis. There's other things that cause it, certain drugs cause it, and connective tissue disease. But as far as connective tissue disease, we'll cover that when we get to rheumatology. So, interstitial lung diseases is the big category, and we said if we can't figure out what causes it, we've done a complete workup. It's termed idiopathic pulmonary fibrosis, or the more modern term that we use is usual interstitial pneumonia. So this is what we tend to call it nowadays. It's the more modern, updated term. Okay, it usually comes on as a gradual kind of onset of non-productive cough and dyspnea. So remember the 3 C's: cough, clubbing, and I already forgot. Let's go back. Cough, clubbing, and coarse crackles. I thought it was crackles, but I didn't want to tell you wrong. Now we'll remember it forever. All right, keep going. So we usually hear bibasilar crackles. That's pretty pathognomonic, right? Bibasilar crackles, they almost sound like Velcro. We also have no fever and systemic findings, typically in idiopathic pulmonary fibrosis. Clubbing is seen, and in late phases, because of the chronic problems with the lungs, chronic fibrosis of the lungs, we get shunting of blood, higher pressure in the lung system, which backs up to the heart, which causes ventricular hypertrophy of the right ventricle, which then causes filling defects, and it backs up, and we get essentially right heart failure, and that's termed cor pulmonale because the right heart failure is coming from the lungs and not the heart itself. We'll talk more about cor pulmonale when we get to the vascular lung disorders. All right, so how do we diagnose IPF or UIP, whichever you want to call it? For usually, kind of the historical term is IPF, but like I said, the modern name for it is going to be usual interstitial pneumonia. So we diagnose it when there's no associated cause evident. Essentially, it's a diagnosis of exclusion. It says that it can be made with confidence, 90% confidence in age 65 or over. And these are patients with idiopathic disease with history and inspiratory crackles. They also have restrictive physiology on PFTs, so we see a low TLC on PFTs and a low DLCO. A characteristic IUP pattern on high resolution CT. Remember we said when we get those high resolution CTs, you can classify it better. We see these bibasilar opacities with honeycombing. If you see that on a test, it's likely this, okay? And if we have a good idea that this is what it is, based on these findings, history, physical exam, PFTs, and CT, then patients do not always have to have a surgical lung biopsy, especially those that are older, because biopsies where they are relatively low risk can lead to problems in the older population. Obviously, as well as the disease progresses, we also have to assess the patient for pulmonary hypertension to help prevent cor pulmonale from forming. All right, more about the diagnosis. So there's really, besides imaging, there's really 3 diagnostic techniques that we use to help diagnose UIP. And the 3 are the bronchoalveolar lavage, the transbronchial biopsy, and surgical lung biopsy. So, and with the surgical lung biopsy, I don't know if you can remember back to our pneumothorax lecture, where we repaired it via a VATS procedure. Remember, we go kind of like laparoscopic surgery. They can do that biopsy by VATS. Or they can do it by open procedure. So let's talk about a bronchoalveolar lavage, or BAL. It can provide specific diagnosis, especially if it's an infection, and you basically take some of the fluid out and you run cytologic examinations. You're looking for malignant cells, different types of cells from infection, and things like that. So a transbronchial biopsy is where you use a bronchoscope. So you go down with a camera, and then you through the bronchial, you actually take a piece of the tissue that's abnormal, and you look at it under the microscope to see what the characteristic findings are. And last but not least, and like we said, the best diagnostic test is going to be the surgical lung biopsy. And like it mentions here, we don't just get one little piece. We usually get 2 or 3 from different sites on the same lung, and they compare it to normal tissue, and that helps specify the diagnosis, okay? Patients under 60 without specific diagnosis generally should undergo surgical lung biopsy. Remember, we mentioned in the previous slide, patients age 65 or older, we can kind of weigh the risks and benefits, because there is a morbidity related to the lung biopsy, like we mentioned. So you have to kind of weigh the risks and benefits for that. And if you don't end up doing a surgical lung biopsy, you can just use empiric therapy, okay? Or maybe even no treatment, just depends. Like we said, other diagnostic and radiology, we mentioned chest x-ray. We can kind of see a little bit of changes there, but the high resolution CT is much better at seeing them. We also mentioned PFTs. And then depending on if we are suspecting the rheumatologic type disorders, we can run some factors and things, but we won't really go into that too much. How do we treat patients with UIP? Well, first of all, unless you are in the field of pulmonology, you will probably not be treating these patients. They are highly specialized treatments that are done on them. They have to be closely monitored, and they should be under the care of a pulmonologist. The problem with UIP is that there's no good treatment. Essentially, nothing alters the outcome. There's some immunosuppressive therapies, glucocorticoids, and cytotoxic agents, but none of them have been proven to be really good, especially at altering the outcome. And the one other thing we can do, just like in hypoxemia from COPD, is we can give the patient oxygen therapy. The real only definitive treatment is lung transplant. You have to take out their lungs, put in new lungs. And the 5-year survival for that is about 50%. So it's not a good thing to have by any means. But and you do have to go through a process to diagnose UIP, because you have to rule everything else out that we're about to talk about before you can call it UIP. All right, next we're going to go into sarcoidosis. Now, sarcoidosis is something that's pretty rare. I've actually never seen it in real life, I guess you could say. But in the vignette world, in the PANTS world, on our test world, you are going to see sarcoidosis. And the thing about sarcoidosis is it's actually really hard to diagnose in the real world, but in vignette world, it's pretty easy if you know what to look for. So I'm going to try to help you figure out what to look for sarcoidosis. It's a systemic disease, causes multiple symptoms in multiple systems, and the characteristic findings that we see are non-caseating granulomas and bilateral hilar adenopathy. If you see that on a test question in a 40-ish year old, 30-ish or 40-ish year old African American female, it is sarcoidosis. You can rest your head on that, okay? This is the classic findings, characteristic findings. As you can see here, third and fourth decade of life is who we tend to see. African American are the most common, and as well as Northern European whites. I'll tell you, common things are common. Most of the time in vignettes, they like to classify or use youngish, third and fourth decade African American female as the patient, because that is the most common type of patient that we see. The difficult thing about sarcoidosis is because it causes all these kind of seemingly random symptoms in different systems. If you see it in the real world, or if you see it kind of mismatched with all sorts of other system questions, like on your pack rat or your pants, it can be hard if you don't know what you're looking for, because it causes such a constellation of symptoms. But if you can remember the non-caseating granulomas, bilateral hilar adenopathy in a 30 to 40-year-old female that's African American, you're going to get it right. Okay? The good thing about sarcoidosis is it has essentially, most of the time, pretty good outcomes, a lot better than some of the other interstitial lung diseases. So how do patients present? They usually have, this is why it's so difficult, non-specific constitutional symptoms. Malaise, fever, anorexia, weight loss. Kind of sounds like the flu, TB, maybe cancer, right? There's a bunch of things it kind of presents like lymphoma, right? Other things that it presents with outside of the constitutional symptoms, 25% of cases involve the skin. So we get erythema nodosum, lupus pernio, which I'll show you a picture of in a minute. On the eyes, it's affected. So anterior uveitis or iritis. And that's the most common eye finding that we see. You can also get granulomas in the eye. The heart can have problems like cardiomyopathy. You have trouble with the musculoskeletal system, arthralgias, arthritis, and the nervous system. Especially like a Bell's palsy you can get, some papilledema and peripheral neuropathy. So you can see it kind of touches on a lot of different systems, which makes it tricky to diagnose. In some cases, patients even present asymptomatic. They have no symptoms and get the chest x-ray and you're like, whoa, what is that bilateral hilar adenopathy? Crazy, right? And I think, oh, maybe it could be sarcoidosis, right? Differential. So TB is definitely on the differential. There's some fungal type pneumonias that can present this way. Tularemia and brucellosis, which are not common. Parasitic infections like toxo, Berylliosis, lymphoma, like we mentioned, and any type of really granulomatous disease, you can have trouble identifying. So here's kind of a slide that shows us some of the other manifestations that happen with sarcoidosis. We have, this is lupus pernio. It is a poor indicator. If patients have this, they generally have more advanced disease. Whereas erythema nodosum, which are usually kind of on the flexor surface and the extensor surface of the forearms and extensor surface of the lower legs. In an African American patient, it looks kind of like dark, but erythema, red, nodosum nodules in a lighter skinned patient would look more reddish colored, and these painful nodules that appear on the arms and legs. That's actually a good indicator. If patients have erythema nodosum, they tend to have a more benign case of sarcoidosis. Other things we mentioned, eye involvement, anterior uveitis or iritis, inflammation, and they also can get these granulomas and some changes on the retina. Other things it causes are right here. Hepatosplenomegaly is there. Some kidney granulomas in kidneys. Granulomas in the lungs, arthritis, heart problems, and lymph nodes, like we mentioned. How do we diagnose sarcoidosis? Well, we combine clinical picture plus radiographic information and histologic findings. So, one, non-caseating granulomas on histopathology. Okay, Then we combine the way that it looks on CT or X-ray, and we can exclude other diseases that have the same picture. So when we ask patients that we think could have sarcoidosis or have that picture, want to ask them about exposure, especially occupational or environmental. Have you been working in a textile factory? Do you work with electronics or silica? Do you work with quartz or sandblasting? Those kind of things. Did you work on shipbuilding, 50 years ago? Those are the kind of things we want to ask, right? Generally speaking, we can rule that out by history. Physical exam, you're going to do all those exams on all those extra things that we just talked about. Again, chest x-ray, bilateral hilar adenopathy is a hallmark finding. Do all patients with sarcoidosis have to have that finding? No, only about 50% have it. But if they do, likely have sarcoidosis. Also, pleural effusions can be present. If they are present, they tend to be more exudative than transudative, and only about 10% of patients get that. As far as staging for the disease, there's really 4 distinct stages. The first is having the disease with a normal chest x-ray. Okay, that's stage 0. So hard to diagnose a patient at stage 0. Stage 1, it has hilar adenopathy. Stage 2 has hilar adenopathy plus interstitial infiltrates. And stage 3 has interstitial infiltrates. Stage 4 is fibrocystic changes. So you can see there's a progression of disease. I don't expect you to know staging for my test, but it is good to know that there is staging that exists. Like we mentioned before when we were talking about interstitial lung disease in general, high-resolution CTs are good at pinpointing different things, especially when you find things on the chest x-ray like the hilar adenopathy. Bronchial alveolar lavage can help us see kind of the CD4 helper cells and things like that, but it doesn't establish a diagnosis in all patients. The most accurate diagnostic test, like we mentioned before, is a lung or lymph node biopsy, and it'll show non-caseating granulomas. Got it? Other laboratory findings we see in these patients, they tend to be hypercalcemic, and they also have hypocalciuria, so extra calcium in their blood and in their urine. ACE, if you see this, ACE, especially if you see the ACE with the bilateral hilar adenopathy and the non-caseing granulomas, you can sure bet that this is sarcoidosis. Okay, only about 40 to 80% of patients have positive ACE levels or elevated ACE levels, but if you see this combined with the other things, it is sarcoidosis. And then here's some other things you're looking for. Neither finding of those two, hypercalcemia or ACE levels, is sensitive or specific to make the diagnosis by itself. You can also have a non-specific ESR elevation. Okay, signs of inflammation in other words. The sarcoidosis is actually kind of funny when we look at it on PFTs. It can be restrictive or occasionally can be obstructive in nature. And we also get EKGs because, remember, it can affect the heart. We look for conduction disturbances and dysrhythmias. All right, how do we treat sarcoidosis? Well, the good thing is that most cases resolve spontaneously. We have to do nothing for them. But the mainstay of treatment for sarcoidosis is systemic oral corticosteroids. So steroids for sarcoidosis, SNS, okay? And the indications are going to be having any of these symptoms listed here, and sometimes long-term therapy is required, okay? If that doesn't work, if the initiation of corticosteroids doesn't work, then we consider giving methotrexate and other immunosuppressive medications. Patients, even though it can resolve on its own, do require long-term follow-up, and they should have physical exam, PFTs, chemistries, and an ophthalmologic evaluation, also a chest radiograph, initially a chest x-ray, and then maybe even a high-resolution CT, and an EKG. Cool. All right, so we moved on from sarcoidosis. Now we're going to cover the occupational pulmonary diseases. And we are not going to go into a lot of depth on these. We're going to kind of skim the surface because, one, they're not very common if you do see it, but you have to know that it exists so that if someone tells you something and kind of turn a light bulb on in your head, like, I think I remember hearing about that in PA school. Remember Professor Gonzalez talking about coal mining, and yeah, I think maybe that's what's the cause, right? So I'm just gonna kind of refresh your memory, get it in your head at least very superficially, and then hopefully if you need it, you'll be able to recall it when you need it. The other thing is that on tests, they usually kind of give it to you. You just have to know it. You just have to know it. For today's lecture, we're mainly going to focus on 1 and 2. Okay, especially 1 and very little on 2. Okay, these are other things that do cause occupational pulmonary disease. So essentially, it means that you're exposed to things on the job that cause your disease. All right, the pneumoconiasis are the ones we're going to talk about next. This is the ones that are usually inorganic, right? Inorganic. So any lung disease caused by inhalation of organic or non-organic airborne dust and fibers. Okay, so it can be organic, like in the case of Byssinosis, so like textiles, but most of them are non-organic. They're dust and fibers that we have. And patients work on the job, they inhale the abnormal dust and things, it goes into their lungs, and the longer you work in that job, the more frequent encountered, the more you inhale that, the worse off you are, and the more chance of you getting the interstitial lung disease and changes in the lungs. The ones we see the most are asbestosis, silicosis, and coal miner's lung. There's also Berylliosis and Byssinosis. They're less commonly seen. Those are the ones we're going to focus on today. They tend to cause inflammation and lead to fibrosis of the lung, and this is irreversible damage that they have to the lung. So you have to have a clinical suspicion for this. You have to ask about the occupational history to know that that's even on your differential to begin with. So you must always ask about occupation and what patients are exposing themselves to when you're taking a history of someone with dyspnea or with cough. Okay. On X-ray, you're going to see this pulmonary fibrosis, and like we mentioned before, exposure to inhalants, characteristic X-ray findings, and absent of any other illness that can be mistaken for pneumoconiasis. So you have to be sure that that's what it is. Here they are, kind of in a bird's eye view. The pneumoconiosis, or pneumoconiasis, whichever way you want to pronounce it. And like I said, the ones we're going to focus on the most are asbestosis, silicosis, coal workers pneumoconiasis, and we're also going to talk about Berylliosis and Byssinosis. These other ones we're not going to talk about as much, but it shows you the disease, the agent, and the occupations that are more at risk. All right, so let's talk about coal workers pneumoconiasis. I think it's the easiest one because it says it in the name. Who are the ones that tend to get it? It's the folks that tend to work in the coal mines. It's also kind of referred to as a black lung disease, and it usually takes a period of over 15 to 20 years of exposure before you start seeing these signs and symptoms. Most cases are mild, but they can lead to severe fibrosis, restrictive lung disease, and you can get some nodules, and they're usually located in the upper lobes. They're usually kind of rounded and located in the upper lobes. And the way I like to remember this is that coal workers work down in the mine, so the lesions are up in the upper lungs. It's opposite of what you think. And that's consistent through all of the pneumoconiases, and we'll talk about each one as they come. So patients work down in the mines, and the lesions appear up in the upper lungs in the apex. The other way I like to think about it is because they're dust fibers, they can kind of free float. So when you breathe them in, they can kind of free float up to the top. Okay? Symptoms, they're pretty nonspecific most of the time. Some can have associated chronic bronchitis, COPD, and then there's this other syndrome that they have, sometimes they test on. It's rare, but it's essentially the pneumoconiasis nodules paired with rheumatoid arthritis. So if you see that, that is Kaplan syndrome. What do we see on chest x-ray? Well, we mentioned small apical nodular opacities. And PFTs are, of course, going to show you restrictive pattern. We are talking about restrictive lung disease today. Treatment, unfortunately, there's really no specific treatment. The main thing you need to do is get them out of that environment. Get them out of that environment of the coal mines. They have to quit work. Next, we're going to talk about asbestosis. We kind of mentioned it when we talk about mesothelioma. Remember, mesothelioma is a type of lung cancer that we see that's related to asbestosis. We see these in patients that work in shipbuilding, house building, kind of way back when. Working in the attics, insulation used to have asbestos fibers, and I'm sure you've seen a commercial with a greedy lawyer that wants your business. If you've been exposed to asbestosis or if you have mesothelioma and they want to work your case for you, probably seen it. Usually develops several years after the exposure, so it takes about 10 to 20 years to really start to show its face. And the good thing is most patients have pretty mild severity, but the ones that have moderate to severe have restrictive lung disease and fibrosis, similar to coal workers' lungs. What I'd like to mention is what's important here is that with asbestos exposure, you have a risk for bronchogenic carcinoma, and smoking and asbestos are synergistic. It's 1 + 1 = 3 in the risk that you have for developing a bronchogenic carcinoma. Okay. Usually symptoms are, again, pretty nonspecific. You have to ask about the occupational exposure. And most patients, like we said, crackles, clubbing cough, plus or minus cyanosis. On chest x-ray, because asbestos usually comes from insulation in the attic, which is up top, the lesions tend to be down in the lower lungs. It's opposite, just similar to the opposites of the other pneumoconiases. So asbestos up in the attic, lesions tend to be down below on the bases. Okay, and you usually get these calcified, so these little areas of calcified pleural plaques, and you also tend to get these little linear patterns, lines of the asbestos exposure. So they tend to be linear, streaking opacities. High resolution in CT is the best because it's able to kind of really detect where the fibrosis is, and it can also show the pleural plaques in better detail. Again, there's really no specific treatment for asbestosis, unfortunately. And the problem is that it takes 10 to 20 years to really start having disease after the years of exposure. So by the time you're starting to show these symptoms, it's kind of too late already. You're going to already have the disease. And one other thing I wanted to mention is when we say asbestosis, asbestosis is the pneumoconiasis. Asbestosis is the pneumoconiasis. It's one of the findings that can happen because of asbestos exposure. So this is asbestos exposure. It's a big category. And within that, there's smaller categories like asbestosis, which causes this type of appearance on the chest x-ray, right? Then you also have mesothelioma, bronchogenic carcinoma that it instigates, right? And other things that fall in this category, which I'm not going to go into more detail with. But I just want you to understand that asbestosis, as it's called, is only a very small part of asbestos exposure and what asbestos can do to the body. Silicosis. Silicosis can also, tricky enough, silicosis can also be found in mining. So depending on what you see on chest x-ray on findings, you could either think a miner has silicosis or it could be coal workers. So you have to kind of differentiate between those two. Other things that we see it from sandblasting, glass cutting, fluorescent sorry, not fluorescent lighting. Sorry, that's something else. Glass cutting or glass manufacturing, stone cutting, quartz comes in quartz. It's essentially sand from sand and rocks and things, right? So you get localized and nodular peribronchial fibrosis. And remember, silica comes from the dirt, sand, and quartz. So it's found, dirt and sand and quartz are found below the earth. So the lesions are up in the upper lobes, tend to see more apical type opacities. And they are also round and nodular, okay? One other thing that is classic of silicosis is this eggshell calcification of the hilar nodes. Eggshell calcification. And on the next slide, I have a better picture of this. The only treatment is quitting your job, getting away from the silica. So this is kind of the dust that these patients breathe in on a regular basis that it exposes them to the silica that causes the silicosis, okay? And these are those little eggshell calcifications. So eggshell has a hard calcified shell on the outside and then matter on the inside. And that's why they call it eggshell pattern, because you have the hard shell on the outside and the yolk in the middle. And that's what they tend to look like, even more so on CT, on high resolution CT. Next up, less common, is Berylliosis. It has kind of acute phase diseases and also has chronic forms. This tends to happen in like NASA, right? And electronic industry, dentists can get it. And back in the day, it used to be in fluorescent lights, like especially those that were before the 1950s. So patients that manufactured fluorescent lights were exposed to it. And remember, this was in the 1950s, so the patient would be much older now after they were exposed. And it's similar to sarcoidosis. You get granulomatous, skin lesions, hypercalcemia. As you can imagine, sometimes they're very hard to differentiate from one to the other, and that's why we tend to get the biopsy. The biopsy tells us what exactly it is. Let's see, what else can we see here? All right, they do have this beryllium lymphocyte proliferation test, which helps diagnose. In this one, you tend to see it affect the upper lobes, okay? And sometimes they might have hyaluradenopathy. PFTs are going to show restrictive pattern. And the good thing about having Berylliosis is that glucocorticoid therapy does help, okay? And that's good. It's one of the few ILDs besides sarcoidosis that responds to steroids, and that makes sense because it's also granulomatous. Last but not least, for the pneumoconiasis, the occupational exposure is going to be Byssinosis, and that's exposure to cotton. So you tend to see it in foreign countries where you have these cotton mills where they are making, cotton that we use to make clothing, textile industries, right? Rope making. In the beginning, with Byssinosis, tend to get this asthma-like symptoms, and it tends to happen. You get it at the end of the first day of the work week. So they call it like Monday chest tightness, where you have the weekend off, you're good. Then you go to work on Monday and you get the symptoms because you've been exposed all day on Monday. So they call it Monday chest tightness. Usually happens with 10 plus years of exposure, and smokers tend to have it worse off, okay? It looks like it also can cause an obstructive pattern. I'm not sure that they would test you on that. I hardly ever see questions on Byssinosis other than relating it to the textile industry. Most of the non-pharmacologic interventions include kind of workplace, fixing the workplace. So having exhaust hoods, you're reducing the exposure to the dust and other OSHA requirements. All right, so another kind of at a glance looking, there's some mnemonics for you to help remember. There's Aztecs and Badasser for lower lobe, and you can see kind of which are the players in each category. Okay. Here's kind of another at a glance chart. It tells you what's the disease, who gets exposed, and what the PFTs show, radiology findings, and complications. So I like at a glance slides. They help me remember, help me memorize. So I put that in here too. Last but not least, and really not least because we're barely going to talk about it, we're mainly talking about it for thoroughness sake, just to say that we did, is hypersensitivity pneumonitis. It's AKA, it seems like a lot of these interstitial lung diseases have these alternate titles, right? Extrinsic allergic alveolitis is another name for it. Here's a chart from your book. Here's the different types of hypersensitivity pneumonitis. The one I tend to see most often is farmer's lung. You get it from moldy hay. Okay? It's essentially caused, again, by inhaling things that don't belong in your lungs, and it's occupation related. The quicker you can make the diagnosis, the better you are at preventing the bad course of illness. The more you're exposed, the worse illness you have. And you usually get these interstitial infiltrates, you get lymphocytes, plasma cells, non-caseating granulomas occasionally in the interstitium and the air spaces. And they're usually organic types of things. How do they look? Generally speaking, patients tend to get it during the work week while they're exposed. They get more symptoms. When they're off, they don't have as much symptoms. And they're usually kind of constitutional, get malaise, chills, look pretty similar to some of the other things we've seen. They also can have crackles, they can have cyanosis, nodular densities, looking a lot like other things we've seen. And that's why getting that biopsy is going to be super important. There are some antibody panels you can get, and PFTs show more restrictive lung disease. And that's really for the acute illness. Remember, most of them have kind of this acute and subacute, more chronic illness. Like we mentioned, biopsy is necessary. Chronic exposure, progressive respiratory insufficiency, fibrosis in the lungs. Same kind of pathophys that we're seeing over and over again. All right, and treatment. Well, you got to figure out what it is that's causing it first. You can occasionally use oral corticosteroids, but the big thing is, sorry to say it, got to get a new job. This is a very blurry chart. I understand that. It comes from Medicosis Perfectionalis. One of my favorite YouTube channels. I think he's really funny. But when he goes through it, this is kind of an overall big picture again. Restrictive lung disease chart. Talks about the extrinsic things we mentioned at the beginning of this lecture, which were kyphoscoliosis, Guillain-Barré, paralysis of the diaphragm, things outside of the lungs. Then it goes into the intrinsic stuff that we talked about. Intrinsic restrictive lung disease is also known as diffuse parenchymal lung disease or interstitial lung disease or ILD. Then we talked about, initially we talked about idiopathic pulmonary fibrosis. We said we didn't have a real reason for it, but that's one of the subcategories. Then we talked about sarcoidosis, which is kind of included in this others category. Then we talked about occupational exposures. We talked about Byssinosis. We talked about coal workers' pneumoconiasis, asbestosis, silicosis, and Berylliosis. And last but not least, we talked about hypersensitivity pneumonitis, which we said the main one is farmer's lung, but there are other ones. There's actually also even coffee workers' lung, believe it or not. Anyways, this is a bird's eye view. Don't get too caught up in the details. The main thing you need to be able to recognize in a vignette is where the patient's working, what they've been exposed to, what are the radiologic findings, and most of these things don't really have treatment. Just remember the ones that do. That's about it. This is the point where you would ask questions if we were live, but we're not, so I'll just ask you a few questions. See you in class.